we will be on case taking, or rather I will say how to approach if you get a case on CA larynx, and similar will be the approach like if it comes a patient of CA hypopharynx or CA nasopharynx, like not nasopharynx basically, hypopharynx and larynx, both the approach basically goes the same. Oral cavity, little bit different questions will be there, which we will discuss during the oral cavity session. Achha, before that, guys, many congratulations to people who cleared their theory. I'll just say that it is actually very hectic, and you'll realize that in every stage we are being like our patience is tested, and clear it up. Okay, as painful is this theory, similarly even more painful is the practical setup. Okay. And people who are unfortunately could not clear it by few marks, there are people who have not cleared it by 1 mark. So you can imagine the pain and agony of those people जिनका एक number से रह गया. So just work up. There will be few points which will again discuss with you. So that please push yourself to the other side of that line. Okay. Now they will take some time to declare the date of that exam. Okay. That. On what day it will be conducted, and generally they might take 1 week से लेके 3 weeks का time is the usual sweet time which they take, DNP takes, and then your center will be declared probably a week prior or 5 days prior, where you are getting your center. Okay, so that is the place like your all patients get tested. Just a minute. Okay, so now basically New Year is also set in. Kindly push your focus towards the practical and push this January month. You might take 2-3 days off. Everybody enjoys on New Year. You should also enjoy. But from 1st of January onwards, make it a point that for the next 45 days, 50 days, give your best. Practicals might somewhere be around in late Feb or March, somewhere around that time. It's never a surety. The NB can play with it. They might pull up the date or they might push it even further. So that will be like, that will get clear with time per se. Okay, so we have time in our hand, so we'll revise it, whatever we have done, we'll revise it once or twice at least. Okay, so going with the today's class, see, for this today's class, what all I have taken, I have taken help of YouTube videos of this TMC, ke jo screen not visible. Guys, is anybody else also having this problem of screen not visible? Are you people able to see the screen?
Yes, sir.
Okay, thank you. Okay. So I have gone through around 2 to 3 videos of your this TMC Viva question, in which all these CA larynx and all these questions were there, and I have compiled the questions. Okay, it's not that regular wale from that question bank I have not taken. Okay, these all like but all I saw during my preparation how to go about it, and okay, but all I went through, and the following amendments I made in that. Accordingly, we should go through. Okay, so let's start. Supposedly, we get this patient that is a case of CA larynx. So how can we go about this? Okay. So let's suppose our patient, Mr. Johnny, that is standard, aged so and so, resident of so and so, profession so and so, came with complaints of. Now, what can be the primary complaints that you people can say over here? The first is dysphonia. Okay, in dysphonia, basically what happens? Generally, the glottis is involved. Hence, it presents earlier. Normally, a patient whose voice is going down, or he is having some hoarseness or something, these problems, generally they present earlier, and therefore their prognosis is better. So this is a very common viva question that Dr. Which of the viva, that is, there will be three subsides, है ना? There will be three subsides of larynx: supraglottis, glottis, and subglottis. ठीक है? Please remember the boundaries and the parts, subsets of these three also. Okay. Then you have to remember the TNM staging of each. You have covered it in this, but yes, ultimately you will have to ratify this. Okay. We have covered it in this, but ultimately ratify करना पड़ेगा. So first, the problem will be dysphonia. Apart from that, what else he can present with? He can present with dysphagia or odynophagia. No. This can also be there in the supraglottis or in the subglottis. So generally, it has a later presentation. And third, they can present with this global sensation. Okay? Global sensation is basically what? That something is being stuck in my throat. Okay? So these questions you have to read about subsides. This is a question. They might interrupt you in between. कि डॉक्टर साहब अच्छा ग्लॉटिस में क्या है, सबग्लॉटिस में क्या है, सुप्राग्लॉटिस में क्या है. TLM staging can come as a viva question also. Okay. Coming to HOPI. Here what you can cover. One thing is you can answer about, sir, the solids more than liquid or to both, whatever. Okay. So over here what you can cover is whether the problem is only to solid, to liquid, or to both. So generally what happens, solid signifies that there is some obstructive lesion, whereas if it is only to liquid, it indicates more towards the neuromuscular disorders. Okay. Then second point which can cover over here is duration. Okay. Like suppose if there is hoarseness of voice, if the patient has come with complaints of hoarseness of voice, but since how long he is having it, is there any history of voice abuse? Okay, because अगर voice abuse का history है तो chances of going towards your vocal polyp and all those things increases more. If there is chances of smoking, then your Rinki's edema and all those things can come into picture. Okay, if there is any history of diurnal variation, okay, so your chances will go towards more of laryngitis. Okay. Apart from that, what else can be covered is just whether there is any history of hemoptysis, neck mass. This should be covered in your HOPI if the patient is having it. Why? It can be met, lymph node, or this might be the only presenting feature. Okay? Mind you, cups is an important theory question also. It's also an important table viva question. Okay? Cups ka, it's very unlikely that you get an entire case of cups only, but be ready. Cups ka definition se lekar ke how to manage a case of cups, it is important. Okay? Any history of ear pain, this can be covered. Okay, so over here your all causes of referred otalgia, wo pathway this can be asked. Okay? Or whether there is any history of weight loss. These are some of the significant points which can be covered in your HOPI. Okay, now there is a point that examiner might stop you and ask you that Dr. What is your initial impression and why? So this will depend upon person to person. Okay, like what happened in two like vivas which I have seen. See, there is a question that why do you think it is larynx and why is it not thyroid? Why are you saying it is larynx malignancy? Why not thyroid? So you can answer it in multiple ways. You can answer what are the pros of your point, sir, the patient is presenting with hoarseness of voice. But if it in case it would have been a thyroid malignancy, to cause a hoarseness of voice, the size of thyroid should be huge, so that it presses back. Okay, but sir, the swelling is not there in thyroid, therefore my DD will be more towards larynx. My impression will be more towards larynx rather than towards thyroid. Okay, so this is how you can defend yourself what you are saying. See, exam mein, there is never absolutely right, there is never absolutely wrong. Okay, so you have to defend whatever you are saying. And the third thing is, never argue with your examiner. Never argue with your examiner. Whatever he is saying, yes sir. Ultimately, if he is shouting also, yes sir. Sorry sir, उसको खत्म करना है. Don't argue back. No sir, I know it. You are wrong. I am correct. Okay, वो नहीं करना. Okay. After that, what else you have to cover? Is there any history of diabetes, hypertension, COPD, TB? Now here examiner might ask you, Doctor, why did you ask the history of COPD and like tuberculosis? Okay, so how you can answer this question? Okay, sir, I am expecting this to be a malignancy of larynx. I am expecting this to be a malignancy of larynx. And in case, sir, after workup, if this turns out to be malignancy of larynx, and I plan surgical intervention for him, like supposedly like total laryngectomy or some surgical procedure on larynx. So, in those cases, the lung capacity is important. Okay? You cannot perform a total laryngectomy on a patient. Like basically, it will be important for the rehab purposes. If the patient is not having any lung reserve, it will be like a futile effort to provide him with voice rehab. Okay. Then comes the very important questions over here, which can be asked to you at any moment in this time. Okay. These will be repeated again in the CA oral cavity also. When we will be discussing oral cavity, 50% of these things will be repeated again. So please go through it again. Okay. What is field catheterization? Please remember the name of the hypothesis. This is Slaughter et al. Hypothesis. Okay. And basically, what does it say? It says that because of that carcinogen, the entire aerodigestive tract is exposed to the carcinogen. Hence, there are chances that even after one single malignancy, it can be also there in some other subsite also. Okay. Now comes one of the very favorite questions. Why is smoking important? Okay. So now can somebody unmute and take a track? What all carcinogens are present in smoking?
Nicotine.
Yes, great, doctor. Anything else apart from that which somebody likes to add? Okay, so this can come as a possible viva question, and believe me, after nicotine, we all will go blank. Okay, we all will go blank. So please have a look over this paragraph. I've only completed the important thing over here. The carcinogens in the cigarette smoke include polycyclic aromatic hydrocarbons, nitrosamines, aromatic amines, aldehydes, organic hydrocarbons and metals. ठीक है? Apart from nicotine. ठीक है? Nicotine तो है ही. ठीक है? He is the big daddy of everything. It should be there. But after this, you should not stop. है ना? And nitrosamine, aldehydes, hydrocarbons, all these things should come one by one. Okay. Now comes again an important question. What is the importance of smoking and alcohol together? Now again, can somebody like to take a try?
The synergistic effect.
Great. The first thing is it has a synergistic effect. There are 5 points. Okay, at least you have to speak 5. 6 to 6. Okay, there is synergistic effect. Okay, something else? Try. Same thing in CA oral cavity also. This question is predominantly from your CA oral cavity section. Like cigarette and alcohol, if you take it together, will it be more harmful or only harmful if their value take cigarette alone or smoking like alcohol alone? Okay, so it's an important question. Any other point would you like to add, somebody? No? I'll add. Okay. Sorry. Alcohol acts as a solvent. Okay. alcohol acts as a solvent for all these carcinogens which we have seen above. Second thing, we had read in our organic chemistry days before NEET PMT that alcohol oxidize होकर के aldehyde बनता है. तो C2H5OH है, ये होकर के क्या बनेगा? Acetaldehyde. This acetaldehyde is toxic. Okay. Then what happens? That this alcohol basically, what does it do? It upregulates enzymes, especially cytochrome P450. Now इसकी वजह से क्या होता है? There are multiple pro-carcinogens which activate, ये इसको activate कर देता है. It gets activated and form multiple carcinogens. Got it? Then जो alcohol है, it decreases the activity of DNA repair. The activity of DNA repair. Okay. Then, apart from that, these five are important. These all are like it impairs the immunity. And generally, it is seen that a person who consumes lots and lots of alcohol, his nutritional deficiency goes off for a 6. Okay? So, Doctor, please rectify this. This is given in your Scott Brown 8th edition. Okay? I have not taken it from any other place, only from Scott Brown. Please remember these points. It is a very important Viva question. Okay? So, moving ahead. Okay? Moving ahead, importance of ये आपने बता दिया. Now we come to a important thing which is called as familial malignancy. Now, what is this? When you say family history, okay? See, if you get something in long case, na, so like what is the standard format? Please go as per that standard format only. Hai? Don't try to think that oh, my case is Larynx, so I'll not speak about past history. I'll not speak about family history. Please, if it is a long case, go from A to Z as like it has been ingrained. Like these are the presenting complaints, these are the HOPI, this is the past history, this is the treatment history, this is the family history, XYZ पूरा with dietary history सब कुछ डालना है. ठीक है? Even in the case of females, if your patient is a lady patient, please in your case sheet write menstrual history, write that obstetric history. That if that examiner fingers you that you have not taken, to give it the case sheet, sir, I have taken it. Okay? Don't get caught on those fronts. Okay. So, you will say what? Sir, family history is nil significant here, not important. And just look at the examiner for a stare. He might ask you, like, what were you expecting in family history? Or do you know anything which, like, familial cancers, kuch pata hai? So, say, yes, sir, I know this answer. So, now can somebody take a try? 2-3 important things.
The Fanconi's.
Yes. Dr. Chhatra. Fanconi's anemia. Great. Anything else?
Ataxia.
Ataxia telangiectasia. ये भी Scott Brown का पैराग्राफ है. This is also a paragraph from the great Scott Brown. The problem with Scott Brown is, as a resident, when we read it, we never get it. Even during my residency also, I hardly remember क्या था कुछ मैंने पढ़ा था. But when I started going through again, so every time, I think this is the I would have gone through it 3-4 number of times. For every session which I take, I go through back again. So every time I find a new point. अच्छा ये भी पूछ सकते हैं, ये भी पूछ सकते हैं करके. So that is the, I'll say, beauty or whatever you can say. Okay. Apart from that, I'll answer for you. Bloom syndrome. Okay. So let's see over here. ठीक है. Inherited cancer syndromes में you will be having Lynch too. ठीक है? Okay, see, if they want to make it difficult, they might even ask you what gene is it causing mutation on. Bloom syndrome, BLM gene. ये सब एक नंबर का आएगा. And because of 1 mark like these, there will be 5-10 questions which will be the deciding factors. ठीक है? Get my point, please. है ना? These are few things which you should not miss. Okay, then xeroderma pigmentosa, ataxia telangiectasia, Lee-Fromeni syndrome. See all the mutations. ठीक है? See all the mutations. So please remember 3-4 out of them. This is the Slaughter hypothesis, that is a field cancellation of your oral cancers. Okay, so moving ahead. Okay, so you will give the history, whether the patient smokes, whether the patient drinks. Okay, over here I would like to say there is a Ratnagiri belt in the Konkan areas of Maharashtra. There people use tobacco paste. Okay, and what the call is basically mishri bolte hain. नहीं, tobacco paste is different. There is one more thing called as mishri. Mishri is basically a sort of type of tobacco which they use in the parts of UP, Bihar and Maharashtra. They'll say mishri lagate hain, and normally what is mishri to us? Mishri is a kind of sweet thing which is generally given after as an offering after puja and all. Okay, but this is also a your thing, subset of your tobacco only. Okay. Now, can somebody take a answer? Pipe smoking से which type of cancer is prominent? And reverse smoking से कौन सा होता है?
Hard palate.
हाँ, कौन सा है hard palate?
Reverse smoking.
Reverse smoking. Okay. And pipe से?
Lip cancer.
Lip cancer. Okay. अच्छा, lip cancer से मुझे question याद आया. There are multiple named flaps in the lip section. I'll share with you. We'll discuss upon that. Carapant, Zek, flat, like very odd names are there. 5-6 drawings are there. Right? You have to go through them. Right? So please mark this question. Hard palate is important. Reverse smoking is like basically the last strip of smoke which is left. So generally they reverse the cigarette and somebody else will smoke from opposite end into the mouth. Okay. So when I saw it for the first time in front of my own eyes, I was like, okay, this is like what people do. And when I read about it, कि अच्छा hard palate से ये हो रहा है, तो I came to realize the terms. Okay. So now over here, then again 2 more questions over here. When you start to say about the examination of the patient, है ना? So you'll say the general condition is fair or he's sitting comfortably in a chair. Generally, you'll get a patient who will be comfortable, who will not be like एकदम downgraded patient नहीं मिलेगा, है ना? So whatever is the condition, you will have to answer. Whatever is BP, you have to answer. Your pulse, you have to answer. ठीक है? Generalize what you say, no pallor icterus, edema, lymphadenopathy, you have to answer. And over here only, you should answer about the performance scale. Now, what all questions can come over here? First is ECOG. So first question is ECOG का full form is an individual question in itself. So can somebody take a try and give me the answer? बोलो. Eastern. अरे बोलो. Cooperative Oncology Group. ठीक है? Here they give it on a scale of 0 to 5. And Karnofsky में कहाँ से देते हैं? 0 to 100. ठीक है? Why is it important? Why this performance scale is important? This is basically first to generalize what is the status of patient. Second, to know how is the performance, like basically you treat him, you do surgery for him, you have planned chemotherapy and radiotherapy for him, and he comes back after some time and he files a case against you. You know, sir, आपके treatment, because of your treatment, my condition has like even more worse. So there you can quote it like this was the scale before the treatment and this is the scale after the treatment. So basically it's a medical legal also. Okay, so this is how. This is ECOG. 0 is fully active, 5 is dead. Okay? And similar thing is for Karnofsky. So my advice to you will be learn at least one. Okay? If you are able to learn both, fair enough. And the thing is, some people in some institution they follow ECOG, ECOG, and in some people in some institutions they follow Karnofsky. Okay, so you can follow whatever your institution tells you to follow, and this is a very I'll say a mindful answer, that even if you get stuck somewhere and examiner says why are you doing so, and you say you feel that this is not entirely wrong, okay, कि एकदम गलत पे नहीं बोलना ये चीज, so you can say sir we follow, this is our institutional protocol, so that's why I remember it. Like suppose exam like for exam purposes I was not able to remember this Karnofsky somehow, so like we used to follow ECOG in our setup. ECOG 0 1 2 3 4 5, 5 तो कभी आएगा नहीं, 0 1 2 3 करके आता है. He might ask you what is ECOG 1, what is ECOG 2, what is ECOG 3. This is one question. And we used to say, sir, like if somebody asks you what is Karnofsky, so I used to answer only ECOG. Sir, in our institution we follow ECOG, so that's why I remember ECOG. So it gives the impression that you are working in your institution. Okay. Then go ahead, like जो आपका larynx का examination है, please don't put it at the first. जो बाकी routine वाले हैं, please go ahead all about it. How do you go about it? That is your oral cavity, all your points. How is the mouth opening of the patient? Whether you can see any pre-malignant lesions like leukoplakia, erythroplakia, OMSF. Okay. How is the oral hygiene of the patient? All things. What is the dental status of the patient? How are the lips of the patient? How is the alveolus of the patient? Okay. How is the anterior 2/3 of the tongue of the patient? Any ulcer, whether associated with it or not? How is the hard palate of the patient? How is the retromolar trigone of the patient? अच्छा, RMT के anatomy is a question, okay? People, for theory, it's also an important question, and even Viva also, they might ask you what is retromolar trigone and what is its importance. Okay. Then goes your oropharynx. So without saying all about tonsils, posterior pharyngeal wall, uvula, and base of tongue. There can be a possibility that in your institution something of this sort can be coming in on the other subside. So whatever you have been following, please follow that. Okay. Third is neck. Don't forget to examine neck. Okay. So you have to see about any swelling or not. And second, laryngeal crepitus. Now, can somebody take a try कि laryngeal crepitus plus or minus, अगर laryngeal crepitus नहीं है तो what does that signify?
Malignancy.
अरे malignancy तो है ही. What does? हाँ, it's going into the posterior cricoid region, basically in the prevertebral region. So that is why that larynx is not. जब larynx को हम rub करते हैं, when we rub that larynx वाला like protuberance, if there we rub, where do we rub? Basically spine का जो protuberance होता है, उस पे भी rub it. So if that crepitus is not coming, what does that mean? Yeah, it's going in the post-cricoid region or in the prevertebral region. Like अगर ये, sorry. This is his nose. ठीक है, this is neck. तो neck पे थोड़ा सा protuberance है, and यहाँ पे पीछे spine आ रहा है. So what do? We hold this larynx like this, and we start rubbing it over here. So basically, यहाँ पे अगर something gets filled, so what will happen? It will not be able to get rubbed behind. So that signifies that either the malignancy has spread to the postcricoid and the prevertebral region. Okay, moving ahead. There is a name sign also after this. So that will be a question for you. Okay, now coming to this. Yes, Doctor. Great. So keep practicing like this. It shouldn't happen that your mind should be running in all directions. ये नहीं कि बोका साइन जब मैं साइंस पढ़ूंगी तब पढ़ूंगी ना. Whenever we are going, all these things should keep running into your mind. Okay. Now then comes your ideal examination. Now it's my request. Generally, see, you will be very unlucky if you get this case as a long case, because very unlikely, very unlikely you will get. Even if it comes, it can be a table viva type ward round. May you can get it, but very unlikely you get it for a long case. But still, please keep an ideal mirror with you in your kit, which you will be carrying. I'll be sharing with you what all to carry for the exam a week prior to you. Okay, please put an ideal mirror there. Now what happens? I'm like though for examination purposes we are told to do ideal, but in practical world nobody does ideal these days. We have to do a endoscopy for the patient. You have to do a Hopkins endoscopy. Okay, but still for the exam purposes you have to know about ideal examination. Okay, in ideal examination 2-3 things are there. One is the technique. Okay. What do you see? That you have to mention. And third is your image. Now, over here only I would like to take this thing of similar thing called as posterior rhinoscopy. ठीक है, इसका भी टेक्निक, how you do posterior rhinoscopy, ठीक, what do you see and image, both of them are a question in itself. ठीक है, and believe me, nobody does posterior rhinoscopy these days. Everybody does a diagnostic nasal endoscopy. We have endoscopes in our hand, but still for the exam purposes we have to find it, we have to answer it. So this is important. Okay, because in one you have to depress the tongue, in one you have to hold the tongue. Okay, so and examiners are so sadu ki tumne agar like if you make the slightest of mistake, they'll say okay, thank you, move to the next question. So please practice it. Okay, if you are confused in it, please let me know. Okay, I'll tell you what are the answers for this. Okay, but please go through them once and keep practicing. Like if it comes in your viva, how will you approach it? See, knowing the answer is one thing, but telling the same thing to the examiner, making him believe that you know the answer is another thing. So these 6-8 weeks, which whatever you have with you, please practice it. Please, if you practice it in front of the mirror, that is great, absolutely great. Nahi to still in a lonely place, in a secluded place where you can talk to yourself, ask these questions to yourself and try answering it. Okay, try answering it. It will make you much more confident and you will be able to have a better impression on the examiner. Okay, so you have to okay, drawing you have done it. Okay, now then you can come to the diagnosis per se. If you are able to visualize anything on the Hopkins exam, this examination. Okay, sir, there is a 2x2 centimeter ulceroproliferative growth or ulcerative growth mass arising from supposedly, I'll say, right TVC or left TVC. Okay, involving, always write involving. Okay, involving means what all structures it is touching, and is it overhanging somewhere, that you have to write. What are the mobility of the cords, that you have to comment. Okay, and whether the glottic chink is adequate or not. These are the 5 points which you have to cover in your diagnosis. Okay, now coming to the the most important point of any viva. See, believe me, in a long case or in any short case also, I'll say, after 2-3 vivas, examiner gets bored by the same thing. So basically he wants to understand do you know how to manage the case. Same goes for the CM's commerce, as we have seen. How will you manage the case? How will you manage the case? So your answer should be, sir, I would like to investigate the patient further. For investigation, what you will do? First will be your endoscopy examination. Okay, then goes a radiological examination. Now there is always a war between whether you will do a CCT, whether you will do a MRI. So MRI is better for soft tissues. We know that. But there are few important indications also where MRI is indicated. First is growth of buccal mucosa, growth of lateral border of tongue. Okay, so this is important, and everywhere advantage and disadvantage you can say. Okay, like CT is commonly available. Okay. Timing, it is a quick thing. Cost. Then comes your role of PET CT. Like I have done my this thing from a government setup. So PET CT was a I'll say very expensive thing, and we didn't had in our setup. We have to refer the patient to outside and get it. But whatever thing now I'm seeing on the other side of the world, people generally get PET CT done on the first instance and go ahead with the malignancy patient. Okay. I'll be sharing with you at the end of this class what are the important questions, what are the points that you have to go of very high yielding point. Definitely a question will be there. TL will be one of them. TL is total laryngectomy will be one of them. Now, in total laryngectomy, there is always a dilemma whether thyroidectomy will be a part of total laryngectomy or not. So you have to mention your points whether you would like to do thyroidectomy along with TL or not. I'll be like addressing total laryngectomy as TL only. Okay. So the point which you should know is 2-3 things. And first, MRI is the choice. Okay. You have to look about the nodal disease. What is the nodal status? If it is positive in jugular chain, generally thyroid is at risk. So it's better to go with surgery of thyroid also, removal of thyroid also. Then if thyroid cartilage is invasion, so this is the thing which the resident will answer at the first. If thyroid is involved, we'll remove it. It's a common thing. So please answer it. And in transglottic CA, which covers more than 1 centimeter below glottis. These are the things in which the thyroid is at risk and performing a thyroidectomy as a part of TL is recommended. Okay. Then what you will do? You will do a DL scopy for the patient or examination under anesthesia and mapping of the growth. Then the question with DL scope is, what are the hidden areas of larynx? Okay. So can somebody tell me what are the hidden areas of larynx? Try, otherwise we'll sleep off.
Anterior commissure.
Anterior commissure, good.
Infrahyoid epiglottis.
कौन सा epiglottis? Infrahyoid, yeah.
Infrahyoid.
Infrahyoid epiglottis. ठीक. Something else?
Posterior cricoid region.
Ventricles. And cricoid वाला आपने क्या बोला? I was not able to get it.
Posterior cricoid region.
Posterior cricoid region, yeah. ठीक है. Anything else?
Apex of pyriform sign.
Apex of pyriform fossa. ठीक है. Then there will be subglottis also, which is generally not visible. Then even if you are probed further, कि और बताओ, so it is pre-epiglottic space. And fistule it goes और बताओ to base of tongue. But it will stop over here. These are subglottis. 6, 7, 8 are like still examiner keeps on asking you anything else do you know, so these will be the answer. Okay. Then this next question is direct laryngoscopy and indirect laryngoscopy में difference क्या है? ठीक है. Traditional old question. Now coming to two valuable things. What are NCCN guidelines? What is the full form of NCCN guidelines? So it stands for National Comprehensive Cancer Network. Full form याद रखना है, ठीक है. Then there's something called as AJCC 8th edition. What you have to remember is what are the changes in AJCC. अच्छा full form क्या है इसका? AJCC का can try करो.
American Joint Committee of Cancer.
Okay. Good. ठीक है. तो इसका आपको what you have to see what are the changes in latest जो which I have if I am not wrong 8th edition is the latest. Last edition till last was 8. This I have not checked it recently. Have you come across anything else after 8? 9 तो किसी ने नहीं देखा ना अभी तक?
No, sir.
No, na? हाँ, ठीक है. So I have this PDF. What are the changes in 8th edition? I'll share it with you. Okay. So please go through it. Changes is important. There are 2-3 changes. Mostly in that thyroid section, they have changed. So that's why I have not included it here. So that is important. Now, coming to this thing, I'll only go point wise, like basically what questions you have supposed to answer. Okay. Now, supposedly, Dr. Saab, if somebody asks you, anybody can take a try. Dr. Saab, what are the indications of total laryngectomy? So how will you go about it? Dr. Keshri, want to try?
T4A lesions.
T4 lesion. Anything else? Somebody else? Any other thing apart from involvement of larynx के हिसाब से कुछ और कारण होता है?
Recurrent or failure of previous surgeries.
Got it. ठीक है, तो recurrence of disease. अच्छा. Anything else? एक और बचा? चलो, I'll write it. Chronic aspiration. ठीक है. And read about why first total laryngectomy was performed, and you will find something new also. ठीक है. Now, second comes this Gluck and Sorensen incision. ठीक है. Please remember the incision. ठीक है. There are multiple, around 7-8 incisions in neck, around 4-5 in your nose. है ना. So neck का one incision, Gluck Sorensen, is very common. You all know about it. So please go through it. One. Then goes your steps. Okay, so like how you devascularize the larynx, how you divide these stap muscles. So those are the part of this thing. And after these steps, there will be 2 questions which I have included the PDF images in the PDF itself. Then comes the complication. Any surgery, major surgery which we do, basically there are few complications which are associated with it. Okay, so like if somebody asks you in this viva, what are the complications of total laryngectomy, please divide it intraoperative and postoperative. Okay, these are intraoperative, these are the like things which can occur. These are the postoperative. Okay, now I'll just like to take an answer. What are the percentage of injury to RLN after total laryngectomy? So shall I say this in exam? Ki sir, RLN injury can be a complication.
It's sacrificed in total.
Exactly. I wanted to like just bring it out. It's an important thing, है ना? We have this thing in our mind कि sir RLN को चोट लग जाएगी. Generally it is for that thyroid वाला thing. When we are removing the entire house, full house we have removed it. So what is that कि there is inside a door in the house that will get injured? No, it is definitely it's gonna go only. Okay, so this is not a complication. Okay, please remember it. This is not a complication. ठीक है, तो ये गलती नहीं करना है. This is a very common mistake, and this will like lead you through the other way. After the RLN injury, second thing will be your pharyngocutaneous fistula, where you will be tricked. ठीक है, pharyngocutaneous fistula. Okay, so you have to identify it. One, second, they'll ask you how to treat this pharyngocutaneous fistula. So you should be ready to answer. Sir, initially we'll be giving compression dressing. If it is not healing within 14 days, so we can go for the surgical intervention. And then goes stomal recurrence. Now, can somebody take a try that what is the name classification of stomal recurrence?
Classification.
Atia and Seasons classification. ठीक है. We have a great actor in Bollywood, Sunil Shetty. उनका बेटी है Atia Shetty, है ना? Like you can make it resembling with something. Atia Shetty and Seasons classification. ठीक है, तो this in itself is a potential question. Okay, now coming to this question. So doctor, they are asking you in this patient, identify what is this blue mark, what is this yellow mark. I'll make it clear. See, this is yellow, this is blue. Now,
ट्राई करो, ब्लू क्या है? यस, ब्लू इज दी पीसीएफ, ठीक है. एंड येलो क्या है?
स्टोमा.
ठीक है, येलो इज द स्टोमा. नाउ द सेम पेशेंट आफ्टर सर्जरी, ठीक है, what they have done, they have put a flap, and this is the region which they have restored with the flap, and this is the stoma which is still there. They have used a DP flap over here. I'll share the article with you, okay, go through it. Now second question, identify this suture and what is the use of this suture. दिख रहा है ये? This suture, name of the suture is, see, this is sternum, this is mentum. उल्टा बोल दिया मैंने, ये sternum है, ये mentum है, ठीक है. So this is sternomental suture. The importance is, see, you can see this patient, ये इसको ये किया हुआ है, total laryngectomy करके stoma they have made it, so that the patient does not extend his neck too much. He will keep his neck in a flexed position. This is already tight over here, okay. So please remember it. This is done after like extensive pharyngectomy or total laryngectomy के बाद ये करता है. Now बस in quick 5 to 10 minutes I'll share with you the important things in Scott Brown which you should remember, okay. See, this is an important viva point, that this is the association between cigarette smoking and laryngeal cancer. So generally if you answer in figures, देखो एक, there is one thing is you say yes sir, cigarette smoking and cancer is very common, but if you say sir there is relative risk between smokers and non-smoker, and if you tell this thing sir it is 15.5 in men and 12.4 in women, so your aura increases over there in front of the examiner and your chances of getting more than 50% mark increases, ठीक है. Second, the combined use of tobacco and alcohol increases the risk of laryngeal cancer by over 50% of the risk. Again, it's important. Now, these are the other factors which you should, they might ask you, you have told about smoking, you have told about alcohol. What are other factors which can be associated with CA larynx? Sir, it is nickel, there is mustard gas exposure. These are the occupations which are at risk. We saw in the starting, his profession, what is his profession? So he might ask you, Doctor, why did you ask about his profession? So you must tell him, sir, this is exposure to some machines, car mechanics, they are at increased risk. This is the battery plant. So all these people have increased risk. Radiation exposure, that you have to say, and A, C, and E, that you have to say. Okay. Now again, see this thing. Laryngeal carcinoma may risk in smoker and drinker is up to 177 times higher than the risk in non-smoker. What they ask is, or generally they ask is, okay, you are saying that okay, after smoking he'll get CA larynx, and there is a person A who smokes and there is a person who doesn't smoke. Now what is the chances that A will develop more? So you can quote this thing, sir, as per Scott Brown 8th edition, this is in the person who smokes and drink, risk is 4 to 177 times higher. Okay, it will give a better impression. So these are the subsides of larynx. Then this is the TNM staging. तीनों का अलग है, supraglottis, glottis and subglottis. Please ratify it. Don't keep it for the last day. I'm telling you, there are multiple stagings which you have to remember. एक यही नहीं है. Larynx के अलावा C oral cavity will be eat your head. Nasopharyngeal carcinoma will eat your head, thyroid will eat your head, and what not. Okay, so please finish it. एक आध दिन ले लो, remember it, and once you completely clear it, then move it to the other part. Now, ये हो गया, done. Then bus last 2 minutes, please bear with me. Okay, so these are few important points. Please go through it. One is your thyroplasty. पहले टाइप 1 खत्म करना, टाइप 1 हो जाए तब टाइप 2 पे जाना, उसके बाद 3 and 4. It shouldn't happen you jump upon type 4 and you forget type 1. ठीक है, तो then it's useless. ठीक है, all about Ishiki classification you should remember. Then comes your Kaufman formula. This is important. Then management of bilateral abductor palsy. इसमें Kashima procedure is very important. ठीक है. Then goes your total laryngectomy, rehab of total laryngectomy, and basically the TEP part. It's important. Then goes your pharyngocutaneous fistula and stomal recurrence. ठीक है. Please bookmark it wherever you want to do it. Please revise them. These are few of the most important MCQs, not MCQs, basically the potential questions, okay, which can be there either in the OSCE setup or they will be asked in the Viva or table Viva. Okay, so over here I'll rest my case. If there is any point from your side, please let me know. Positive, negative, any input you want to share, okay, please let me know. हाँ बताइए.
But in ideal finding, you told 2 into 2 centimeter perfecto growth, no sir, astro-perfecto growth. You have to mention dimensions in carcinoma or growth larynx, sir. We can do.
See, this was basically more of a depictive thing. See, if truly speaking, if I put myself in your place now, so on ideal, I will not be able to tell what is the size of the growth. Okay, but if see, the thing is, if you are able to see anything, so you can just say, sir, there is a ulceroproliferative mass arising from so and so place, because the things will not be very clear on ideal examination. So you can skip that part. You can just go with this thing, sir, there is so and so ulcerative growth from this part of the larynx, whether it's from the right side or the left side. One thing you have to comment. Second thing is with which main point you are able to see from where is it arising. Okay. Okay. Anything else from anybody? No. If not, then okay, we'll call it a day, and we'll meet again as per the schedule, and we'll let you know about multiple other things. The only thing is, keep half an hour at least अभी पढ़ते रहना. अभी result आ गया है, so after this New Year thing goes, उसके बाद please increase it, है ना? Believe me, like the theory was tough ना, practical is even more tough. ठीक है? I'm not making you afraid, but I'm just it shouldn't happen कि exam के समय जाकर के you realize कि oh, had I known this, so I would have studied very hard. Now, this is the time which you have to put your best foot forward. The coming 1 to 1.5 months, please give your best show so that clear this thing in your go. Don't leave it कि मैं देख लूँगा type से. This is not your MS exam. You have to work hard for that. So, see you guys. In case of any problem, please let me know. And there are few people whose messages I couldn't reply back. I'll just get back to you. Got stuck in because of few commitments in the hospital itself. We'll see you back. Chalo, all the best. Bye. Good night.